That was a very fantastic conversation, Dr. Harris, and I can see we're getting lots of questions for all our speakers. So I think we should just dive straight in because we may run out of time. Dr. Gillies, Professor Gillies, I'll come to you first with a comment and another question from Lena. She thanks you for your wonderful, your great talk. And it's great that UK and Germany studies have reported no HIV transmissions in those who chose to breastfeed. But it should be said that the numbers of women is low, the 151 and 47, with an expected transmission rate of 0.3%, you would expect to see no transmission in this number. It does mean that the risk is zero, and this should be a very important piece of information. Would you, sorry, I've lost the question. That should be an important piece of information to make sure that those making infant feeding choices to make an informed choice. And I'm sure you'd agree with that. I'll go into a question from Krista. She thanks you again for your presentation on breastfeeding and including the words of women and parents living with HIV throughout your presentation. Thank you. Can you express the importance of including women living with HIV in efforts around education, research, and policy around this topic? And if you can share any successful examples from the Nourish UK study.
Great, thank you very much, Fungi, for both of those. So I'll start first with Lena Sagide's question. Thank you, Lena. And I agree completely. They are small numbers, but this is the first and only data that we have. Therefore, it's good that we're starting to build up data, but we need to continue to collect this data. I think saying that you would expect no transmissions if you're comparing the PROMISE study, remember that pregnancy itself is not a zero risk of transmission, and we don't stop women from getting pregnant. And in the PROMISE study, women will already have gone through pregnancy and then breastfed. So the transmission is 0.3% within that study. So women where there would have been in utero exclusions, in utero transmissions would potentially be excluded from that 0.3%. So you're thinking about women through pregnancy and then breastfeeding. And in the UK, our risk is 0.22. So the risk is not zero. I absolutely understand that. But I think it's discussing the evidence base with women is really the key so that women can then decide what they want to do. But I think the risk of banning breastfeeding or saying you disagree with it, you run the risk of a woman feeling she is not approved of and feeling that she will need to breastfeed in secret, which does not help anybody. So supportive breastfeeding in the context of as much safety as possible is really key. And I think Krista's question, thank you so much. I think really involving women from the beginning is hugely important, and Fungi knows this. We are both trustees of SWIFT, where we really want women to be at the key point where you ask the questions that are important to women. Therefore, women would potentially want to be more involved in research if you're doing research that interests them, not just deciding what they might want to be involved in. And actually, Nourish study is a prime example. Prime was a great example, but Nourish is fantastic. So Nourish has always included women living with HIV. So one of the co-investigators, Angelina Namiba, is a woman living with HIV. 5 mothers living with HIV were involved in the patient public involvement and are part of the advisory board. And also the main researcher is a woman living with HIV, Bakisa Quesada, and she has given me permission to express that. All of this has served to produce and shape a study design that will improve recruitment, will have methods that women will actually be interested in being involved in, and will also influence how they analyse and disseminate the information. And the BEVA guidelines, we also always involve women living with HIV. We have at least 2 representatives on our guidelines. Women are essential to this conversation. We can't do any of this without the women. So thank you very much for that comment and question, Krista.
Natella, do you want to take a question or should we carry on with breastfeeding?
Oh, I think let's give it round and come back, because clearly the breastfeeding audience has been more than active at this meeting and takes over any conversation. So if it's okay with you, Fungi, let's go on a couple of other questions. We will come back on the breastfeeding topic. So we just have every panelist an opportunity to speak. I have a couple of questions for Rachel, and I have a couple of questions for Alice. So Rachel, from Dawn A, thank you for the fantastic presentation. Given your extensive work on PrEP, do you think it will take a contraceptive co-formulation co-delivery mechanism to see large-scale uptake for both people at risk as well as for OBGYN comfort? So basically, do we need this dual combination for it to take off? First question. Muted.
I am muted and I am on some kind of a delay. I hope not, in that I hope it doesn't take quite that long. That said, I do think that the co-formulations are uniquely responsive to what women have said they want. And they are formulated and cater to women in a way that PrEP has not historically catered to cisgender women. And I think that's really important in terms of reaching women where they are and what their needs are. Along the same lines, co-formulation with vaginal rings, patches, pills, etc., also squarely puts this in the wheelhouse of OBGYNs. That said, again, I hope that it doesn't take the years it will take to release these MPTs to get OBGYNs squarely on board and primary care providers squarely on board with PrEP provision.
Thank you so much, Rachel. And now a question to you, second question to you before we move to Alice is from Lily Pollack. Rachel, great presentation. Do you have patient input on the intervention? We hear from patients about their reactions of being offered PrEP. And do you know if the people who initiated PrEP continued? Thank you.
Thank you. So although this was a clinic level intervention, we really did focus primarily on providers, given that we thought they were the limiting reagent, so to speak. We do have some qualitative data from patients, and it was overall, in terms of acceptability, very positive. That said, we did get a lot of reactions that PrEP isn't for me, this isn't for me, this is for gay men, this is for other people, this is for commercial sex workers, this isn't for women like me. Reflecting, I think, what's seen in social media and what is advertised. Other women were shocked and outraged that no one had told them about this before. Why didn't I know that this was for me, that this was an option? So we saw the full range of qualitative responses, and our ongoing study actually does address the patient response a lot more directly. In terms of continuation, we saw approximately 50% persistence of PrEP at 3 months of women that did initiate. And we have a qualitative study of key informant interviews, or rather semi-structured interviews looking at 20 such women who initiated and understanding why they did or did not continue.
Thank you very much, Rachel. I will move on a couple of questions for Alice, and then return to breastfeeding because it clearly dominates, and then come back to Peter Hunt and Meile. Two questions, very concrete questions for you, Alice. Are there any studies from Angelina Namiba? Are there any studies looking at continual long-acting cabotegravir, pivaring, or any other LARs in pregnancy?
Thanks. That's a great question. And I think that's such a huge knowledge gap right now. If I recall correctly, I think Dr. Parul Patel earlier in this workshop mentioned that ViiV was going to be planning on looking at pharmacokinetics of this long-acting combination in pregnancy. I know the impact study, ongoing impact study, is also planning on looking at pharmacokinetics of cabotegravir, so in pregnancy. So I think really the more information we can get, the better. And as I mentioned with lenacapavir as well, I think, traditionally the approach has been, women participating in these studies have been taken off medication as soon as pregnancy has been detected, but hopefully there's more of a shift now to allowing them to continue to receive the long-acting injections throughout pregnancy, and getting as much information as possible to mimic real life. So hopefully that we get more of that.
And Alice, one more question to you. What from Luz? What do you think about TAP during the first trimester? Should we expect more toxicity than with TDF?
That's a great question, and it's interesting that you get the difference in the guidelines between the DHHS, which does not have that restriction during the first trimester, and then the European stance. I mean, your plasma concentrations of TAF are so much lower compared to for tenofovir compared to TDF. So, you know, on one hand, you might not necessarily expect that there would be more toxicity if you were comparing them. And I think we also are just very aware that in many cases, pregnancy is unplanned. And we have women who, if they're on a TAF-based regimen, you know, by the time pregnancy is detected, they're already well into the first trimester. So, you know, I don't think there would be any, any cause for a major concern, knock on wood.
Thank you, Alice. Thank you very much. To keep us in balance, I'm looking at our time. Maybe what I will propose, Funga, that you take back the stage for now, and then just have a couple of more questions on breastfeeding, but we do give Peter the chance and Miley to answer the questions as well. So let's try to break down for a couple of questions on breastfeeding and then move on with our two other presenters.
Sorry, I was on mute. Yvonne, a question for you from Layla Pollock. She's very curious. I'm curious to hear more about what you think about the importance of exclusive breastfeeding in the area of effective ART. If someone needs to give formula temporarily to get their supply up, or for any other reason, should that be a reason that they have to stop breastfeeding altogether?
So I think it's a really good question, Layla, and thank you. But I think what we do recommend, if somebody is going to breastfeed, we do try and recommend that they exclusively breastfeed, because that is the best evidence base that we have. If milk isn't coming in, or if there's a problem with the baby latching on and this is a persistent problem, well, then I think a woman will need to consider stopping breastfeeding, because we have no data to say that giving formula feed regularly is going to be safe or not safe. Also, we have no data to say having the odd amount of formula feed apart from that early pre-heart era where mixing liquids is not an issue. It's still the same risk, 9 per 1,000, and solids is the main issue. But I think we have to be careful to make sure that we are doing this as safely as possible. Therefore, we need to ask the question, well, why isn't milk coming in? What are the problems with the breastfeeding? You know, do we think this is going to persist? And if we do think it's an issue, then I do think stopping breastfeeding probably would be the safest thing. But the data we have so far would suggest maybe the odd dose of formula feed might not be as deleterious as we always thought it would be. But this is where we need more evidence.
I've got another question for you, Yvonne, from Michaela. With the remaining controversy around breastfeeding in women with HIV, do you have recommendations for clinical documentation of these conversations around choice? I know many clinicians in the US who have one conversation discussing the options, but then will universally document the US stance of breastfeeding is not recommended, mostly for litigation reasons. Any guidance or suggestions? I find this disparity disheartening. Thank you.
I mean, Michaela, I think you asked the question that has really been the key controversial point, I think, when we are discussing the guidelines. I mean, when we did the BEVA guidelines, this was the section that took the most time, the most conversation, and had the most extreme views, I would say. So pediatricians are very, very opposed to breastfeeding. HIV physicians, obstetricians and women living with are more maybe pro-choice, and women living with HIV are really variable. You know, some are really pro breastfeeding, some are really against it. So I think it's really difficult to say that there is an easy line here. I think the fact that the guidelines, including the US guidelines, recommends discussion of the evidence base, I think is really key. And I think at BEVA, at least we have the guidelines that say we can support a woman to breastfeed if her viral load is less than 40 copies per mil, as long as there are certain caveats with additional monitoring. So I think I have no pro forma that I use for documentation. What we do have is a patient information leaflet, and we start to document the conversation from the first antenatal appointment, and we continue that conversation throughout the pregnancy. And also I have a women's health advisor who does that as well. And we engage peer mentors. So we have 4M Mentor Mothers, which are a fantastic peer mentoring organization in the UK who can help women as well. I don't have a concrete answer to your question, but I think information sharing with a woman and documenting as clearly as you can the evidence that you have discussed with her is really the key. And certainly in my clinic, I have a very standard way of talking with women. Therefore, it's, you know, once I document that I've discussed that, it's very clear what I have discussed. And I think that's really it. I think there's no right answer for that, but I think it's allowing women to have that conversation. That's really the important thing.
Looking at the time, let me get to the questions. Thank you very much, Yvonne. Of Peter, I see 2 questions posted for you. One is from Dawn. Wonderful presentation. It sounds like HRT may be even more important for menopausal women to help moderate inflammation and HIV expression, although estradiol did not appear to be adequate. Is that correct?
Yeah, so I think this is it raises a really good question, you know, as to whether hormone replacement therapy, you know, might be an effective therapy to reduce inflammation and downstream from that decrease morbid outcomes. But we're really not at that point yet, right? I think what this calls for is probably a study of hormone replacement therapy in postmenopausal women with HIV to see whether those inflammatory indices are improved, because there's certainly a rationale to think that might be helpful based on the data I shared. You know, it's interesting that, you know, the opposite has been tried, you know, blocking estrogen in postmenopausal women. In the cure field, people want to, you know, harness this mechanism to increase latency reversal, to flush HIV out of its hiding place, if you will. Blocking estrogen with tamoxifen in postmenopausal women with HIV did not seem to help there. That's probably because there just wasn't enough estrogen around. And then the last little caveat here that I think Dawn might be referencing is that estradiol didn't seem to have that much of an effect in cells from men. It only seemed to block latency reversal in cells from women or people who have natal female sex. And so trans women might not benefit in the same way from estradiol in terms of suppression of inflammation as cisgender women.
And
so that's a hypothesis, yeah.
Very close to your answer, Peter. Since you mentioned clinical trials, there is also a question from Joanne Lindsay. Any thoughts on how to get more women recruited into clinical trials? What barriers are there to prevent or reduce tendency for women to join, since you clearly identified it as a gap for your particular line of studies? And I will be honest with you, I was listening thinking this would be the line of study that a lot of women living with HIV would be interested to participate. Could you elaborate on that?
Yeah, so I'm probably not the person to speak to this. I mean, there are far more experts that have been thinking about this in this community than me. And Yvonne has already spoken eloquently about this. But just a few things that I'll say are that what Yvonne highlighted is that oftentimes these studies are designed without the voices of women at the table, and you know, my co-chair in the trial we're leading, Sarah Gianella, has really championed this and reached out both to community groups of women with HIV and also trans women with HIV. We've run the protocol at various stages by, you know, groups to get people's input, and there are things, you know, in the protocol that, you know, not everyone likes, that are barriers, and we're in this constant process of balancing, the need to address the scientific questions in a rigorous way versus inclusion criteria or procedures in the study that might turn some people off. And so we kind of, but I think underlying all of this is like the need for communication, that there may be a lot of distrust between women with HIV or people with HIV in general and the medical establishment. And people just need to know that their concerns are being heard and addressed before they get to some fancy new research study about some inflammatory marker that they've never heard of. I mean, how do you expect me to pay attention to that if I'm worried about intimate partner violence, or I'm worried about putting food on the table, having a place to live? If those are the most important issues, they need to be addressed and at the same time before you can have a meaningful conversation, I think.
Thank you, Peter. I couldn't agree more. And looking at our remaining time for discussion and the last presentation on loneliness, I see one lonely panelist that has not been yet given a chance to speak. And there are quite a bit of questions. I do want to acknowledge your questions have been fantastic and engagement. That's why Fungi and I are struggling. But I think it will be fair distribution, Fungi, for me to pass the word to you now and give Miley a chance to answer multiple questions and comments she received as well.
Yes. Thank you. I've got a question for you from Bakita Kasada. Are impacts of chronic stress on biology and inflammation reversible, fixed, or is this unknown at present?
So they are partially reversible. It is still an early phase. Maybe you don't believe this, but it's difficult to get both researchers, clinicians, and people to actually have an understanding that stress negatively impacts their body, including things like cardiovascular disease. And that whole concept can be sometimes very difficult for people to even accept, because I think we have a lot of stigma around mental health, and because of that, people don't want to actually think about that. But there is evidence that these inflammatory responses are reversible. It's very understudied, however, and I think it is a great area for new research.
I've got another question for you. Could you speak on the factors that could lead the disparity between being more likely to have mental ill health versus not accessing appropriate support among Black, Brits, and Americans?
Yeah, so researchers and clinicians don't like to use this word, but it's structural racism, really, and it is intersectionality. It's a combo of racism, sexism, adverse childhood events, internalized implicit bias. If you're raised a certain way and you're told because of what you look like and where you come from that this pathway is for you, but not that one, then, we start to internalize those societal biases, and it sometimes can negatively affect folks. And so it is all of those things that women are experiencing.
Fantastic. Thank you so much. Just having a look. We've got so many questions coming in. It's a struggle trying to get through them. You are on mute, Natella. I think if you wanted to say something.
That's one very concrete question from Gina Brown for Peter, I believe. Any studies on estrogen and estriol effect on immune parameters? These are the estrogen hormones of menopausal women.
Yeah, I know that there are discussions of doing a study of hormone replacement therapy, but I'm not sure where trial plans stand now. But I do think it's a good study to do.
Okay, thank you so much. Fungi, any question you still have that you want to address to any one of the panelists?
No, I think there's there's just a comment here about from Jennifer. That your topic is connected to an intervention I'm going to be making about stress management and self-care. That's for Dr. Karas. Just looking at the time, I think we've only got a minute and we still have quite a few more questions. And I don't think we've got the...
No, we don't have time.
We don't have the time to address them. So I just wanted to pass back to you, Natella, to close this.
And all the speakers see the questions. So we will try to make sure that in the chat box, we have an opportunity to post those. So even if they're not posted live, there's been an incredibly engaging session. We're very grateful to all of you for fantastic presenters. We flew over so many lifespans and domains of the woman living with HIV life, and not only her, but her surrounding, her children, her partners. We touched on so many aspects, and just extremely grateful for my co-chair as well, because the questions just kept streaming in, and picking up those was challenging. So please do look for the written answers down the line, and we want to take the time and thank you, Yvonne, Rachel, Alice, Peter, Meili, and of course on behalf of myself and Fungi for your engagement and excellent presentations today. Thank you so much, and we are now passing the word to Sharon to close the meeting.
So thanks, Natala, and wow, and congratulations to absolutely everyone on all of the incredible work that you are doing. And I think the quality and the quantity of the data that has been presented at this meeting is truly unprecedented. And despite COVID, you've not only survived, you've thrived. And this conference, like the 11 versions of this meeting before, exemplifies everything that it's supposed to. We're showcasing women researchers, we're mentoring our trainees, we're engaging our community. And I'd like to really strongly encourage all of our presenters to get out there and publish this work so that others can learn of it as well. And although we can't be together for the networking, we've had that opportunity to meet each other. And as part of our theme this year of advancing women in medicine and science, please invite each other to your institutions to give talks. That helps promote women and helps them in their pursuit of their professions, and I encourage you to do so. One of the best parts of this conference is our young investigators, and this year was no exception, and almost half of our oral presentations and our poster discussions this year were presented by the young investigators. And although we'd love to give them all a prize, we can't, but the members of the organizing committee and the scientific committee do together rate the young investigator presentations. We look at their abstracts, we look at their presentation and how they answer the questions, and we come up with a winner. It was really tight this year, and I just want to comment on a couple of people who are our runners-up. So our second runner-up was Shada Swan from Vancouver. So congratulations for your work. Our first runner-up was Laurette Bukasa from London, UK. And I'm very pleased to announce that our winner this year, drum roll, is Bakita Kashada from the United Kingdom, the University of Oxford, for her presentation, Understanding the Factors That Influence Infant Feeding Decisions Among Women Living with HIV in the UK. Bakita, congratulations on your excellent work.
Oh, thank you so much. I wasn't expecting that. Thank you. Thank you very much, everyone.
And so as a consequence of that, Bakita will be given transportation and registration at our meeting next year. And we look forward to seeing further good work from you.
Thank you.
But clearly, there were many people behind the scenes and involved in this conference. Obviously, we could not proceed without the help of our sponsors. And again, this year for gold, V for silver, Gilead, and Janssen for our supporter. I would like to thank all of the speakers, the abstract presenters, the chairs of our sessions, the chairs of our poster discussions, and you, the audience. These are our endorsers, and I thank them as well. But we couldn't do this without viral education, and I think all of us have appreciated Sam and his talent in terms of making this all happen and having us all virtually be together. For Christina for helping with the abstracts, and clearly for Laura for her dedication to this conference and making this all work for us. Many of you didn't have a chance to do everything over the last 3 days, and we recognize that. So there are some enduring materials, and you can get the sessions available on this platform until the 30th of April using your login in details. So thank you, thank you, thank you. We can't be together, but thanks for sending your picture. And here are all of us, and we hope that we will all see each other again. We do really strongly reinforce that you give us our feedback so we know what you liked, what you didn't like. We think we'd like to be together virtually next year, but we want to hear from you. And I think we all pay attention to Dame Dacre's comments during her talk, is that this virtual thing in some ways is easier for women, that you don't have the expense, you don't have the travel, you do have the ability to do this from your home. But how do we balance that against being together and having those interactions, which is so important in this meeting? So we'll only know if we hear from you what was best and what do you want to do for the future. We don't know where the meeting is going to be next year. So are we going to be virtual? Are we going to be together? Are we going to try to cry? We appreciate your comments. I've also extended the title of our workshop. We had from adolescence to menopause, but you know, our women with HIV are living longer. So now it's to menopause and beyond. So we hope you will all join us next year, wherever we may be. And I congratulate all of you on an extremely successful conference, and all the best over the next year, and stay COVID free. Thank you.